All right, we are going to start the show today. Welcome everybody to the town hall. Once again, we are sitting here with empty chairs from our federal representatives. Once again, we sent letters to all of them, and once again, we were ignored. The format tonight is healthcare. We've got 9 overall topics: advanced nurse practice, LGBTQIA healthcare, LGBTQIA plus healthcare, women's healthcare, affordability, vaccines, rural healthcare, veterans healthcare, mental health, and Medicaid. We've invited speakers on each topic. Each of the invited speakers will be given 5 to 7 minutes, and then we want to hear from some of you. We've got little pieces of paper back there. We're going to try to be a little organized. If you want to speak on any of those topics, please go over there, put your name on the piece of paper. That way we can call you up and you can speak on each of the topics. Each speaker called up will be given 1 to 2 minutes to speak on any of those topics related to healthcare. Our goal is to actually hear from as many people as possible, so please do that. We have 2 hours, so understand our time constraints. There will be a timer up front for all of our speakers, and Devin will be saying stop in 1 minute. The microphone is very sensitive, so please don't put it near your mouth. You can see how far it is from mine. If I put it up here, it's very loud. So thank you. If you don't want to speak, there is a poster over there with voting dots. Deb is holding that up, and just you can note the issues that are important to you and your family. We also have initiative petitions out front that can be signed. A little bit of housekeeping. Restrooms are this way. The men's room had a problem earlier today, so around the corner is actually a unisex bathroom that the men can use. With that, I'm going to pass it to Greg to introduce himself. By the way, I always do this. My name is Paul Harper. I'm a member of the county committee. I'm also on the state Democratic committee.
Very good. Yes, that's right. Thank you, Paul. Thank you all for coming. I am State Representative Greg Bush from District 50, which is the south part of Columbia, and I really appreciate you all coming tonight. I am here to listen to you all as well. I wish that we had more people here listening to you, and I think you know the 4 people specifically that I mean who wish were here. I also want to just take a moment and recognize there are some other elected officials in the crowd and some candidates as well. I'm looking at one of my coworkers. Yeah, please. Yeah, Kathy Stein. Yeah, right. We have some candidates as well. Mm-hmm. Very good. That's right. And she is here. Yes. Very good. Yes. Let's see, anybody else that I am missing? No, very good. I am an RN by trade, and right now the only registered nurse in the State House of Representatives, and the very first speaker is speaking to something that's very close to my heart, as well as I'm sure very close to your heart as well, and if it wasn't before you got here, it will be after she's done. Suzanne Opperman is going to be speaking on advanced nurse practice and the difficulty in finding doctors. Suzanne.
The list over there, it needs little stars for what your area of is most important to you. So it goes through all the healthcare issues. I had to put multiple stars, so go right ahead. Just do that. Okay. My first question. How many of you see an advanced practice nurse in your health clinic? An NP, nurse practitioner. Okay, great. Now, our role has expanded through the years. Back in 1975, we had independent practice, and the laws came about to make it so that we were quite restricted. So, according to the U.S. Department of Health, Missouri is number 43 out of the 50 states in healthcare outcomes. Not good, no. So one of the things that I like to look at is the levels of care over time And so the long waits for appointments, anybody waited several months to get an appointment with a new provider? Yeah. And new providers, it can be like 6 months. Yeah. So over the course of time, access to health care, high rates of chronic health care issues, smoking, obesity, alongside of significant rural and urban disparities. St. Louis has the highest infant and mother mortality rate in the country. Wow. That's sad. And it's because it's inner city, and people don't want to work in the city, and that's what happens. So, also, heart disease, cancer, unintentional injuries are the leading causes of death in Missouri. Unintentional injuries. I don't know about you all, but I find I fall a lot more now. So, huh?
It's hard to hear you back here. Yeah, it is.
Hi, Deb. Got it. Okay. So, the 50 rural counties actually are missing healthcare facilities at all. So 50 counties out of the, what do we have, 114? So half the state does not have, and over the last 5 years, 15 hospitals have been closed. Yeah, it's a lot, which makes healthcare less and less accessible for everybody. So let me give you a little rundown on education through the different healthcare providers. So at the University of Missouri, Kansas City, St. Louis, the medical students are offered to have their tuition debt paid off if they stay in Missouri and work in a rural clinic for 3 years. They can't get a place for residencies, so they go to different clinics that are rural and they can stay there. 75% of them leave. They got all their debt paid off. And that's one of the things that the legislation likes to tout is, well, we pay for this. Yeah, well, it's not working. So healthcare providers are desperately needed to meet Missouri citizens' healthcare needs. Additional team members are physician assistants, which their education is a bachelor's, and fortunately they've cut down on this, but it used to be you could have a bachelor's degree in anything and go to PA school for 2 years and be a physician's assistant. And they've really tightened up on that and expect better undergraduate education, but they have to practice in the facility that the physician that they're working with is in. So, just to confuse all the initials, we now have assistant physicians. PA, AP. I think they did it on purpose. So these are graduates that can't from medical school and cannot get placed for a residency. And then they can also go to work in rural clinics and in several years then take their boards, et cetera. So you're talking people that can't get residencies. Problem is that only 25% of graduate medical school students in Missouri choose to stay here. 25%. Not much. Yeah, they go other places. The big city. You know, they're matching their residencies all over the country to get the specialty that they want to be in. I mean, you can't blame them for that. But the money here is not great. So now the issues related to advanced practice nurses, which are nurse practitioners, but also includes nurse anesthetists, nurse midwives, clinical nurse specialists, and so there's many things that come under the umbrella of advanced practice nurses. So for advanced practice nurse, we go have an undergraduate degree in nursing, then we go for at least a master's degree, get certifications, have thousands of clinical hours. Then the push now is for us to go on to doctoral degrees, and by the time I got to be 70, I was like, I don't think so. And I'm addicted to learning, so it was hard for me to go, no. So it's the most restrictive state in the country. Missouri is the most restrictive state for advanced practice nurses, period. So the law requires that we have to be in a collaborative practice with a physician. Well, okay, then we have to pay for that collaborative practice. Now, not everybody charges an arm and a leg to do this, but it can go up to $52,000 for a collaboration for a year for a nurse with a physician. I have a friend who owns asthma allergy clinic, and that's what she has to pay her collaborating physician. Now, by law, they're required to visit the clinic at least every 2 weeks and sign 10% of the advanced practice nurse's notes and be able to do that in clinic. They're required by law. There's no monitoring of that whatsoever. None. None. So we're being held accountable, but they're not. So, as of 2026, roughly 30 states had independent practice for advanced practice nurses. The rest are different shades of collaboration with the nurse practitioner and the physician, so there can be less and less and less, whereas for Missouri, we have to have them be part of everything that we do. How's that for providing health care? And that's the problem, because we've lost people to Kansas, Illinois, Iowa, Arkansas because of our restrictions here. They're like, I'm not doing that. So, questions? By the way, I'm a psychiatric nurse practitioner, and I refuse to be in collaboration. Yes?
Is there any legislation being proposed?
Oh, I had that on here, but I got my 30-minute warning. 30-second warning. 30-second. Yes. There are only, okay, last year we had a bill all the way through the House of Representatives. It sat on the speaker's desk, and they refused to pass it on. He is a surgeon, and he's quite the personality. This year, so far, only 2 bills that are in the Senate have made it 25%. So they're in committee or have been discussed in committee. That's it. And it's not for lack of trying.
This is late in session.
Yeah. But the House of the Chair has to assign these bills to committees, so he chooses not to assign them because he has no intention of us getting practice. None. The chair? Dr. Patterson.
No, I was just gonna say we don't have anybody to talk about this issue. So, Greg, do you as one of the legislators who is also in healthcare, do you have anything to say on this particular issue?
For this one, the advanced practitioners?
As the only nurse in the Missouri House.
So, I mean, everything that Suzanne said is correct. I would just want to speak just a moment about Suzanne. When I was in the Missouri Nurses Association in their Advocacy Institute, she was my mentor and took me through and guided me through the halls of the Capitol. And when she was doing that, I don't think neither she nor I knew that I would be on the other side of the desk, frankly. But thank you for that. Thank you for your guidance and for your mentorship and for your tireless advocacy for patients, for nurses, and making sure that we expand access to care. The reality is we have so much capability that is sitting idle right now when it comes to healthcare professionals, and that's one of the things that when you go down and be an advocate for these issues and such, making sure that you become that individual that a legislator would turn to for advice, for counsel. You become the expert in their office, and that's what she has done. That's what I am still working on doing, but she's had many more years of experience doing that. Right. Right, and that's the last thing is that when the VA actually has independent practice for APRNs as well. So the good news is that Speaker Patterson is terming out. He's running for the Senate, and it seems like the person who will be the next speaker is a lot more amenable to having APRNs with a transition to practice in place and not having to pay this VIG to that's my word anyway, the VIG to physicians for collaborative practice. So thank you again, Suzanne, for doing this. And right on.
And nobody would take it.
Right. Yeah. Thank you. This is a long process, but we have to have short-term, medium-term, and long-term goals. Going to our next individual who I'm really excited to hear her speak. As an elected official sometimes, and I know that the empty chair is here too, sometimes we live in a bubble and don't always hear about what is really important to voters. And so thank you again for coming out, and that's one of the reasons why I'm here and why we're going to keep having these. And I've had them in district and throughout Columbia as well. But Anise is going to be speaking on LGBTQIA plus healthcare. Anise, thank you for coming and for being here today. Anise, very good.
Yeah, my name is Anise. I'm a student at an unnamed university. Do you want it up here? Okay. Yeah. Up here? Okay. Yeah, student about to graduate from medical school in a month and some change. And I'll be leaving the state because the gender affirming care laws in this state and my own access to healthcare is severely limited. So I'm trans. I grew up in St. Louis. I started hormones when I was 17 years old through the WashU's old transgender clinic, the pediatric clinic, which has been shut down since then, and their entire clinic has been significantly reduced. So I did not have a ton of time to prepare for this, but in short, just wanted to tell you guys a little bit about what the state of healthcare for trans people in Missouri looks like right now, and also just talk a little bit about why you should care regardless of your personal affiliation with trans people or knowledge of trans people. So accessing healthcare for trans folks, be that gender affirming care or other types of healthcare, is pretty limited in Missouri and increasingly across the country. There have been several laws and whatever when the Attorney General says something, those sorts of things, limiting what sort of healthcare providers can offer patients, both pediatric patients and also adult patients, regardless of how long you've been on hormones, regardless of your ability to pay for them, et cetera. And so what that looks like right now, anybody under the age of 18 cannot access any form of gender affirming care in the state of Missouri. That means puberty blockers, that means hormones, that means surgery. And mind you, puberty blockers are something that is frequently used for cisgender children. Likely you know somebody in your life who had a precocious puberty, which just means puberty that happened too early, and they then needed medical care to intervene to prevent them from experiencing the social and physical consequences that come with early puberty, whether you know it or not. And then gender affirming hormones are more used to help people physically present the way that they're identifying. And so those are a little more controversial in pediatric patients, although all of the current guidelines for different associations, medical associations, support the use of them in pediatric patients who are able to make decisions for themselves, so folks who are in their teens, essentially. And then surgeries are not accessible in lots of parts of the U.S., but they're straight up illegal here in Missouri for anybody under the age of 18. Additionally, folks who are over the age of 18 cannot access gender affirming care in lots of parts of Missouri. Part of that is physical access, and part of that is also laws that limit that. So Medicaid no longer pays for gender affirming care. That means that if you are on Medicaid, you cannot access hormones without paying out of pocket. There are still ways to go about that. I'm not going to go into that on the camera, but there are ways that you can still access hormones if you're on Medicaid. However, it is significantly limited and significantly changed in the last 4 years that I have been in medical school in Missouri, and the ways that I have seen that be more and more limited. And then finally, you can still access hormones if you have private insurance. It just depends on the insurance's willingness to cover that. And that doesn't even go into accessing surgeries. And so that's going to also be based on your insurance. Of course, Medicaid won't cover that. And private insurances have all sorts of limitations that prevent you from being able to access hormones. Some of the reasons that I think it's really important to all of you who are in the room, likely most of you are not transgender, is that this sort of care impacts everybody. Whether you are trans or not, you are accessing gender affirming care, or people you love are accessing gender affirming care in parts of their lives. And I'd also like to say to begin with, you should care about this because you care about people, and you should care about this because trans people are also people, and we deserve access to health care, and it actually is not, our access to health care should not be contingent on any individual's beliefs or values, religious or otherwise. However, it is also important to remember that this does impact you, and this does impact people you care about. Gender affirming care is something that everybody accesses, like I said. It is the hormone replacement therapy that postmenopausal women, cis women, access. It is the hair transplant that cis men access, and cis women. It is the minoxidil that cis women put on their head when they start losing hair with menopause. It is the minoxidil that cis men use on their head when they start losing their hair naturally in their 30s and they don't like it. It is the testosterone that cis men frequently want to have access to because they don't feel good as they age and their testosterone levels tank. There are all sorts of gender-affirming care that people are accessing on a regular basis. And it is only trans people that are being attacked for that specifically. Additionally, trans people are often the first group of people that are, or one of the first groups of people that are attacked in any setting. And so it is an issue of bodily autonomy, and this is a bit of a canary in a coal mine situation, although we're really way past that at this point. Anybody, I'm sure, in this room can tell you that the bodily autonomy and ability of people to make decisions for themselves in healthcare is severely limited in the state of Missouri and throughout the country right now. But specifically, trans people are kind of at the forefront of that. And so as soon as we let that one pin fall, that is just another step in limiting women's access to birth control. That is something that has not been limited for decades, and to suggest that women should no longer have access to birth control, you can imagine how detrimental that would be. But this is just one step in that tower that folks are trying to push over right now. And finally, it's important to remember that you know trans people, whether you think you do or not. If I'm walking down the street, you're likely not going to know that I'm trans. If I am seeing you in the clinic or in the hospital, you're likely not going to know that I'm trans. But that is something that influences my everyday experience, and that is something that influences how I got to being a doctor. And it is important for everybody to acknowledge and remember that you are interacting with trans people every single day, whether you know it or not. And we deserve your support, just like every other group. And it's really easy to forget that when you are sitting with the privileges of a cis person. But it's really, I implore you to think about that. I implore you to think about trans people going about your daily life, recognizing that 3 out of 100 people are in the umbrella of trans. And you should really be including them in your thoughts and in the way that you're voting, given the context of this. And thinking about that and pushing your elected officials to make decisions that don't hurt trans people and ideally support us. That would be cool, but I'll settle for not hurting us for today. So,
Thank you. So we have one speaker that is speaking on this, and I would just note that, the first shot across the bow was when the legislature about 3 years ago decided to end the ability for children to receive gender-affirming care. And basically, the legislature has not really cared what sort of collateral damage that's happened since then. And I hope Jen's going to be talking about some of that, so I'm going to pass it on to you, Jen Harper, who I know very well.
Thank you. I'm up here as a parent of somebody who identifies in the LGBTQ community. It is not safe for a lot of folks that are part of that community to come out and speak publicly. So kind of using my cis privilege here and sharing with you some of the things that I am seeing. And I am a volunteer at the Center Project. I help with a parent group, and we help educate parents on how they can best support their kids. And, when they're going to school, what are some things you can ask at the school, things like that, so that they can help affirm their child. I have sat in meetings where I've had parents sobbing because their child has lost access to gender-affirming care. It is heartbreaking. Just picture, if you were to suddenly go into puberty for the other gender that you do not identify as, and your body was changing, your hormones were changing, all of those things were happening, and it's the total opposite of what you feel in your heart and your head, it's just devastating. And now these kids in Missouri can no longer access that care. One of the specific things I want to talk about is puberty blockers. Our last speaker talked about that a little bit. It is given to cis kids all the time. That means kids that do not identify as transgender. They're giving it to them because they're really short and they're starting puberty. They're given to them because they're starting their period when they're very young. There are some very good reasons, and guess what? Their parents get to help make that decision. Their doctors get to help make that decision. But if your child identifies as trans, they cannot make that decision, and their parents can't make that decision here in Missouri. And so I just want everybody to kind of think about some of the people in our community that are really suffering right now and how things are really affecting them. Thank you.
Thank you, Jen. Thank you, Anise. I appreciate you coming in. As I was listening to the last two speakers talk, we had a debate on the floor last week about exempting churches from being receptive to public health orders, and this goes back to COVID. And one of the things that kept being brought up is, I don't want the government in my church. I don't want the government in my church. I don't want the government in my healthcare. I don't want the government in my exam rooms for my patients. And that's ultimately what we've had. So thank you both for sharing these experiences. Speaking of government in people's healthcare, Dr. Elizabeth Alman will be talking about women's healthcare. Thank you so much for being here today.
So my topic is women's healthcare, and of course I think sometimes we jump right to access to abortion and contraception, so I'm going to just start there. I want to make sure that everybody knows that right now, as of today, surgical procedural abortions are legal in Missouri and being performed in Kansas City, Columbia, and St. Louis. Yes. Thanks to everyone who worked on Amendment 3 and got that passed, because that is why it's still legal. Technically, medication abortion is legal in Missouri, but it is not happening because the Department of Health and Senior Services has made some silly requirements about the physician who prescribes the medicine has to personally be available 24/7 for 7 days after the prescription is done, and that making arrangements for emergency rooms and such is not okay. This is very similar. We spent 50 years trying to change home birth legislation in Missouri, and this is the similar stuff that folks who don't agree with it would try to do. Is like, well, let's just try to make it safer. So the medication abortions are available in Kansas and in Illinois, and again, they may be available through the mail in ways that I'm unaware of. So I wanted to make sure that everybody knew that. I think when we talk about how important it is to have access to rights, we need to make sure that people are aware of what rights they actually have access to. But just like trans care, gender affirming care is not limited to just the gender affirming part of that. We are whole people. And people who were identified female at birth are also whole people. And we have a little bit more complicated bodies than men, at least from the standpoint of mainstream medicine, which, you know, has been in the hands of men for a long time. Thank you for taking good care of it. But it's time we need to make it a little different. And so we often have put lines around, oh, but if it's about a uterus, then these people can't do it, and the people who are doing it have to pay a lot more malpractice insurance. When rural hospitals close, often the first thing that happens is they close down their labor and delivery unit, and it's not very long after that that the hospital then closes. But so many of the counties that have a hospital or have a doctor's office don't have anybody who can catch a baby or attend a birth or handle a miscarriage or help with a postpartum issue. We have sort of ghettoized the care of pregnancy in a way that makes it hard for women and pregnant people to get holistic health care. I know a person who went to Women's and Children's Hospital here in Columbia, which is no longer a thing, thank goodness. She was in the late part of her pregnancy and she had appendicitis. It took her 7 hours to meet with a surgeon who could remove her appendix. Because, oh, it seems nice that you put all the women's and children's care in one building. Well, the problem is that a woman is not just a uterus. People who have uteruses also have hearts and kidneys and skin and brains. And sometimes pregnancy complications end up affecting all of those organs. So when one of the pressures on women's health care, though, has been on access to abortion. And when we stigmatize and limit access to abortion, we stigmatize and limit access to pregnancy care and to miscarriage care and to contraceptive care and family planning care. So it has always been difficult. As long as I have known, I've been a physician since the 1980s, it has always been difficult for people to access care during a miscarriage. They often haven't gotten their primary care provider yet. There are some obstetrician practices who will not allow you to make your initial visit until you're 12 or 13 weeks, so they won't have to deal with the messiness of a miscarriage. That has got to be increasing, because dealing with a miscarriage in a state where there are criminal penalties for performing an abortion makes it dangerous for the physician to attend, and the nurses, and the advanced practice nurses, and the PAs. The whole team is now in danger of criminal liability. I've been a physician a long time, and I have always been a little concerned about being sued, but I was never subject to criminal charges. I am also a person who has lost several pregnancies. I've been pregnant 5 times. I have 1 living child. It was a challenging journey through all of those things, but I never once worried that if I went for care for a miscarriage or for a term stillbirth, that anyone would call the police. It's hard enough to lose a pregnancy. Most people who've lost a pregnancy can tell you the day, they can tell you what the weather was like, they can tell you who was there, who was kind to them. These are indelibly impacting events in the life of a person who's been pregnant. And the idea that we are going to question, investigate, charge, try, and imprison people for having a miscarriage, which has already happened and is going to keep happening if we don't change things, it means that then there you are with you're pregnant and you're bleeding and you don't want to go in. You don't want to tell friends and family that that happened to you, and so you don't get the emotional support. So it's complex. I think that we need to defend the health care for pregnancy and for people with uteruses and breasts who are not pregnant.
All right, I believe we have one person, Vicki Zimmerman. Was this the one? You sort of circled 2 things here. Did you want to speak for a minute? Well, come on up.
I'm at an extreme disadvantage, but I'll make the best of it.
All right.
Thank you.
1 to 2 minutes, please.
Hi, my name is Vicki Zimmerman. I'm a disabled and retired nurse. In my life, I was raised in rural Missouri. I was on the West Coast, and then I came here. Been here forever. Got that education down there. I've been such a nerd. I gave myself a big favor, and I was a good student. Top 10% of my class. Same way with nursing school with a child. My teacher had no idea how I could do it, but I did it. I don't know how I did it. And so I'm sick right now, so I'm a little rickety here, but I'm still going to do this. Did this as a single person mostly. Was able to accumulate in a shabby neighborhood because I knew it was shabby, but I knew it was going to become a big, important thing. 3 houses in 1 lot. And the big house wasn't paid for, but the other 2 were. The lot was a drug house, tore it down, syringes in it. My son and I, we worked. Well, I got hurt on the job as a nurse, of all things. An obese nurse who needed the help of me. I was obese at the time, really obese, and another nurse, and I got hurt lifting her. So then I had this great big excursion into what I call the Missouri Mafia medical scene, and I, on job injury, lost my job. I was a great nurse. I got a scholarship. I got a plaque, and then when I got hurt, I was told that my injury didn't exist and I was probably mentally ill. I was really mad. Can you see that? And so the day they were going to fire me, I knew they were going to fire me, true to form, and I had a sealed professional business envelope of a letter asking them to let me go. I will quit as opposed to being fired because I was in the process of opening up an adult daycare. I just knew that I could still do this thing. Live upstairs, have a daycare downstairs, great location. So then I went on this odyssey of getting scanned finally. They finally said, yeah, we're going to scan you. And so when I got scanned, they came in real grim because they found kidney cancer. So I'm going, well, got no job, got all these houses I'm rolling around in, got kidney cancer now, so now what? And so what that was is I sold my houses because they wouldn't let me have any help. And the houses were kind of rickety, but they were occupied. Sold my house, sold one of them to my son, turned around and got in there. It took me 2 years to get the kidney cancer out. It was the size of a walnut. By the time I got it out, it was the size of a grapefruit. But it was encapsulated, and I was very fortunate for that because, you know, you can die. Kidney cancer is the 6th leading cause of death to older Americans and is known as a silent killer. So I was blessed because I got hurt on the job because they scanned me early and found it and got it out. Great. Let's keep on rolling. Well, I had a major stroke. I had a stroke. I was flopping around like a big beached whale, and I ended up being in rehab for almost a month. Came out, got certified to be able to drive again. Keep on keeping on. Kept on doing what I could do. I moved down into my unfinished basement. That was going to be my adult daycare, and I got water from upstairs from the people who were renting from me. The people are terrible whenever you're down and out. People don't want to pay their rent. So I'm sitting there high rolling all this stuff. And my son is living in Colombia at this time. And I was doing okay. But my house burned down. So I'm going, oh, something's telling me something. I shouldn't be in this area anymore. And that was in Rolla. I've tried. Beautiful, up and coming, very Republican, kind of naive. I work in night shift too long as a nurse. Anyway, I'm sorry. Listen, I just want to let you know that they're running the doctors to death here. I have a friend named Mark. He was an excellent doctor. He bridged from being a chemistry professor to a doctor, and they've just slapped him with a total of 4,000 patients for one day. I mean, just for a month, for his own personal care. And forgive me for being a little breathless, but I had to come here. I just woke up at 5:30, so I think I did okay. You guys take care.
Thank you. Thank you so much. We have one more audience member on women's health care, Sam Jones.
I will try to keep it to 2 minutes. So, as we have already heard a little bit, women's healthcare and trans healthcare are deeply intertwined. Also, there's intersex healthcare that is also deeply intertwined with this. I was born intersex. I didn't learn I was intersex until I was an adult. And if I had known I was intersex as a kid, I would have been really excited to have a bathroom that I could have changed in by myself. But intersex care, we perform surgeries on intersex babies with pressure from hospitals to do so, at the same time that we are preventing kids who are old enough to make decisions for their own bodily autonomy, and we're preventing them from accessing that care. Thank you. As an intersex person, if my genitals had looked even more different, then I probably would have had my parents pressure me into having this type of surgery, or their doctors would have pressured them into having this surgery. Before I could be old enough to speak for myself, we should not be pressuring intersex people to have surgeries to look either male or female unless that is what they actually want for their own bodies. We should not be pressuring parents to do that either. That is also where it comes to women's health care. Because I am intersex, I cannot give birth. My body is designed in such a way that if I tried to, it would kill me. It was difficult to find a doctor who would perform a tubal ligation on me because I had never had children. To be able to make sure that I didn't die on a surgical table, I had to jump through multiple hoops to find my doctor. And I was 27 when I was able to get my tubal ligation, and that is incredibly young for people to be able to access that, and I am very lucky I was able to, but there are so many people like me, women and non-binary people and trans people alike, who struggle to access this type of birth control. Not only that, it's not affordable. It is not affordable. Health insurance is ungodly expensive. I recently lost my job. I had to go get health care this last week. I called ahead. They were asking $120 just for a doctor's visit to make sure that I could get an antiviral. That's out of pocket. I don't have income. That is half of my weekly income at this point in time while I job search. That's not affordable. I was really lucky that we have a health department that was able to see me for free. That should be what it should be for every single person. It doesn't matter what your income is. You should be able to go to the doctor for free, because that's what our taxes should be going to, rather than Republicans fucking us over. Thank you.
Thank you, Sam. Thank you. This is, I mean, we have people pouring their souls out here in front of us. I wish that the audience was exactly 4 people bigger. Coming up, we have talking about affordability and accessibility. We have Dr. David Mayer, who will be sharing thoughts that need to get to 8 more ears, but hopefully we'll just use you for tonight. Very good. Thank you. Thank you, Dr. Mayer.
This good volume? Okay. So you've already heard plenty about issues of affordability and accessibility, which are interrelated issues. You've heard that we've had multiple rural hospitals close. You know, within just the last few years, we had the hospitals in Mexico and Fulton close. They were bought by a private equity firm, firms which historically tend to rape businesses for whatever they can get, and often send them into bankruptcy. So we lost 2 of our rural hospitals that way. We're looking forward to, as I think other people are going to talk about, Medicaid cuts coming with our favorite president's big, beautiful bill. Not so beautiful. This has the potential to cause multiple further hospitals in rural areas to close. So care is much less accessible in rural areas. Emergency care is much less accessible in rural areas. Without hospitals, you've got inability to get all kinds of care that people may need, forcing them to travel much longer distances. And then on top of that, we have the issues of being unable to get appointments. So I'm a specialist in geriatric care. People who are older call me up all the time and say, who can I go to see who's good with older adults? Well, I usually have a list of several people, but I always say, you know, if you're lucky, you might be able to get in 3 to 4 months. It might be 9 months. So primary care, specialty care, both are incredibly difficult to access if you don't have an established relationship. And even if you do, it may still be difficult to get in when you need care. One of the other issues that's related to this is for managed care plans, Medicare Advantage plans, is so-called narrow networks. So narrow networks are agreements that insurance plans have with specific providers that the people who have those plans can go to them and they can't go to other people. So how does this play out? Well, one example that I heard about just recently, this is not an older person, this is a younger person, a woman in her 30s had an abnormal pap smear, needed to, this was done by Planned Parenthood. She needed to get referred to some place that could do the next level of evaluation, what's called colposcopy. She tried to go to the university, but it turned out her health insurance plan didn't include the university in its provider panel. She was going to have to go to either Kansas City or St. Louis to find a provider that could do this procedure for her. There are many other examples, and this is a major problem in terms of people getting the care that they need, particularly if they have something unusual that may require specialized care that's even not available in the area that they're in. We already heard about increasing costs of insurance. I have some friends who are pretty middle class. They have been depending on the healthcare marketplace through Obamacare. Their premiums this year, with the changes in the law, went up to $2,000 a month, and they wouldn't get any benefits unless they had expenses over many thousands of dollars, even after paying that much money. It was totally unaffordable. They decided they had to go uninsured. And what happens for people who are uninsured? People who are uninsured actually have to pay more than people who, even if you had to pay the full amount that insurance would allow, you have to pay far more if you're uninsured, because insurance companies negotiate with healthcare institutions to reduce what the hospital or the health system is willing to accept, called the allowable charge. But the healthcare systems have costs that are much higher than these allowable charges. And if you don't have health insurance, you're stuck with the full charge that nobody with insurance has to deal with. And then finally, the issue of people not coming in because they don't have health care. I recently helped care for a patient in the hospital with esophageal cancer who waited many months to get any care despite having major symptoms of difficulty swallowing, because he was wanting to wait until he qualified for Medicare, which turned out to be quite a long time, and his care became much more complicated. And I'll stop there.
Thank you, Dr. Mayer. Affordability, accessibility. $1.5 trillion, if you've been following the news. $1.5 trillion for the military for next year the president is asking for. So back of the envelope math, $47,000 a second, $2.5 million a minute, and the federal government could give the state of Missouri a full budget, $52 billion in about 14 days. That's what we could do with that amount of money. I'm not saying that's what we should do with that amount of money, but I find investing in people a lot better than investing in death across the world. Next up, we have Annie. Is here. Eisenbei's going to be talking about, so I was a bedside nurse during COVID, and she's going to be talking about some vaccines. Thank you for coming up, Annie Eisenberg.
Thank you. All right. I'm a newbie here to speak. So first of all, I just want to say I've been very moved by everyone who's come up and spoken before me. So I'm really excited to be here and talking to you about vaccines, and especially talking to you about vaccines in a trusted local space. So I'm going to give a brief background on myself, and I'll kind of share why I love that I came after accessibility and affordability, because I think it all plays in. So I'm a pharmacist. I've worked in community pharmacies in urban and rural spaces. I now work at the Missouri Pharmacy Association. I kind of carved out a position for myself about 7 or 8 years ago in tying pharmacists in with public health and with public health initiatives. And this was pre-pandemic. So during the pandemic, that role was, exponentially more, maybe not important, but busy. Trying to connect everyone and get things where we needed them and the information that was most accurate, et cetera. I also serve as the vice president for the Missouri Immunization Coalition, which we lost our funding last year, so I'll talk a little bit about that. But so it's really just volunteers, myself and the president, Linnell Phillips, and our board. And then additionally, I've trained hundreds of pharmacists, pharmacy technicians, and students to be vaccinators. And then additionally, we created the very first pharmacy technician training to be dually trained as community health workers in addressing social determinants of health, especially in the community setting. So trying to tie all of that together. And I say that first because we all need a CHW to help us navigate this complex and bizarrely complicated healthcare system at times, or sometimes all the time. And I'm going to share all of those kind of background information because when I usually talk about vaccines, it's to pharmacists or pharmacy folks. And I give a case example, but I'm going to share with you all, I'm the case example. So I was pregnant with my second child. My first child was under 3. She was about 2.5. And my husband and I all live together. So I was fully up to date on my vaccines, so was my 2-year-old, and so was my husband before I got pregnant with my second child. And I can say that because I've now trained hundreds of people on the eligibility of vaccines, right? So in this short time frame of 9 months, in order to make sure that we were still up to date before baby Jack was born, we had to go to 4 different places. And that includes our pediatrician's office and primary care. I actually count those as one. An OBGYN's office, our health department, and our pharmacy. And actually, we had to go to those places multiple times in order for all of us to be fully up to date and vaccinated. Now, if you add in the fact that I'm not a pharmacist and I know to call all of these places and what vaccines I needed to get, because at the time RSV was only open to me for 4 weeks and it had just become available, so the health department didn't have it yet. Add in transportation. What if I didn't have reliable transportation? Add in childcare. What if childcare, okay, it does, cost me an arm and a leg, and I couldn't pick up my child in time to get her to someplace because they closed, or I couldn't take off work to get us where we needed to go, or cost, or access. What if I didn't trust any of these listed providers for various reasons that we've seen people come up before and talk about? So the fear factor alone is enough for any mom to not want to open their door and go into the healthcare space. And so I share that because to the accessibility point, there is a huge list of things that could have stopped us from getting vaccinated. And I was an advocate for it, and it took me forever and 4 different trips and 4 different places. And so additionally, we've had recent issues now, not making it less complicated to help our community members and all try to stay as healthy as possible, but we're making it more complicated. So we've lost federal funding, like for our Missouri Immunization Coalition. I feel like if you even mention vaccine in a grant application in the federal space, I mean, you definitely can't mention health equity. We had to take that off of some of the names that we were involved with and change them. Now they're community health. There's been changes to recommendations and experts being, swapped out for new experts at various locations like the CDC or FDA, and then changing things like universal recommendations. While that may seem like, okay, we're targeting the vaccine for people who really need it, it actually also makes it more complicated because then it's not covered for people who think they need it or want it or know that they need it and have worked with providers and worked with others. So I think when cost is going to be a barrier, because we live in America and we have a very expensive healthcare system, making sure that our preventive care is covered is really important. And then the other is with the coverage component, I just want to share too before I leave, I want to make sure that if nothing else, you know where to go for trusted vaccine information. The first thing too, I'm sorry, my notes are all over the place because I just kept having more ideas as I heard people talk. I wanted to share too, you hear about herd immunity. And so part of the reason that I wanted to make sure that my entire family was up to date was so that baby Jack could be protected, so that when we went and visited my great-grandparents in the nursing home, that they would be protected, that we weren't exposing anyone we loved to a preventable disease. There's enough out there that we can't prevent, so we want to prevent those that we loved. And so with herd immunity, if they can't get vaccinated, or even if they can, and the vaccine's not going to be strong enough because their immune system isn't able to fight and create those antibodies to fight, that we're protecting them. And so I like to talk about vaccines a little bit differently. I 100% agree that healthcare decisions should be made by the individual and their trusted healthcare team only. But when we're talking about vaccines, we also need to talk about this in the space of we love other people and we love our community and our local community members, and we should be thinking about them as well when we're thinking about preventive care. So before I leave the podium, I want to make sure that you know where to go for trusted vaccine information. I find a lot of times that people know they can get a flu shot and a COVID shot at a pharmacy. But if you're an adult, you can walk into a pharmacy and get almost any vaccine without needing to go anywhere else. There's a few exceptions, like some travel vaccines and rabies, but there's very few exceptions if you're an adult to need that. And I'll add, there's updates to vaccine recommendations all the time, so make sure that you're getting that information, that you're checking that box, and then the health department as well. I think if you're going to a pharmacy that doesn't help you figure out what vaccines you're eligible for or make sure you're able to get them, then go to a different one. And I'll just highlight, I use Kilgore's, D&H, and Flo's because they're my local independents, so I had to give a plug in for them. All right, thank you so much. I want to highlight your shirt changes. I've noticed them.
Thank you. All right. We have one community member, Alice Turner. 2 minutes, please.
Annie, that was great. You really covered children, herd immunity that I was going to talk about, but I'll talk about it again. Because what I'm going to start with, I have to look in my heart, who would I want gone from this administration the most? I actually want RFK gone the most, because he's hurting children and hurting parents. Starting with, as we brought early in his administration, when he came out with his COVID recommendations, only us elderly, and we have to actually, I think, be sick elderly, and someone has to write that down, can get covered for a free COVID shot. Not pregnant women who are at high risk if they get COVID. Not young children who are at high risk. These are the kind of recommendations these ridiculous, unqualified people in Washington are making about our health. And people don't really know. When the measles outbreak started in Texas, what did RFK say? Take vitamin A. Take vitamin A. Don't get your children, I mean, it's not really necessary. Don't get your children, they don't need the vaccine. So people started getting sick from overdoses of vitamin A. Their recommendations not only bring on low vaccination rates, getting epidemics happening in our country, but they make them sick from his alternatives. There was an article in the Boone County paper recently that looked at vaccination rates for measles in Missouri. And as you would expect, Boone County had better rates for years. But guess what? They're not so good now. I think they're probably below herd immunity now, even in Boone County. So it's an incredibly great vaccine. 97% effective to have a vaccine shot. But if you're not vaccinated, and it's incredibly contagious too. So that's what we could be exposed on any bus, on any plane. Wear your mask on planes. The personal story I wanted to bring up, you really brought up. My young grandson, we were going to have a family reunion, the first time in like 10 years, because we differ politically, unfortunately. And we were going to have this 30 seconds, and my grandson was 7 months old. And I looked it up. Oh no, he can't have the measles shot till 1? No, this isn't safe. He has to fly on an airplane. I'm terrified. This is my grandson. His parents looked into it. He could get the shot early, but it means he needed 2 of those shots, which are pretty strong shots. Okay, here's the good news. A lower judge just is reforming the ACIP. It's the group that makes advisory decisions, saying the people on there are unqualified. So they have to reform it. So I just wanted to end with that. Thank you.
Thank you, Alice. Thank you. So in 2019, RFK went to Samoa and told them to stop vaccinating their kids. When it comes to measles, 83 kids died. That is who is running our health department. We'll put health in quotations. Coming up next, thank you very much, Annie, by the way. I really appreciate it. My grandfather is a polio survivor, so it was very close to me, making sure that we stay healthy and do things to prevent from getting sick. Am I doing rural health care? I will be doing, Jamie Blair is here to do rural health care. Thank you so much for being here, Jamie.
Thank you so much for having me. And before I get started, I just wanted to Dr. Metz's point, it wasn't originally in my testimony today, but I wanted to make it very clear that Medicare Advantage is a scam. It's incredibly predatory, and it's being perpetrated on rural people, and they're not being told about these networks, so thousands of people are going without care because of Medicare Advantage. Now I'll get started on my prepared testimony. I'm Jamie Blair with the Missouri Rural Crisis Center. We are a farm and rural membership-based grassroots advocacy organization who have been working for the last 40 years to promote family farms and lift the voices of rural communities. We got started out of the farm mortgage crisis of the 1980s, and we soon realized that the crisis wasn't limited to foreclosures and wasn't going to be resolved without diligent and tireless efforts on nearly every policy front. That most certainly includes health care. Decades of bad farm policy has collided with decades of bad health policy, leading us to the rural healthcare crisis that we face today. Rural Missourians are facing drastic cuts to services that we rely on, including the very existence of our hospitals. 29 of Missouri's hospitals are at risk of closure, with 12 of those at risk of immediate closure. Some of those hospitals are operating on 48-hour budgets. And it's not as if we had a surplus of hospitals to begin with. Rural resident drive times are to the nearest hospital are often greater than an hour. Sometimes it's up to 3. That's upwards of an hour to check in with your specialist, access routine screenings, and worse, emergency care. What that looks like in practice, delays in care. If you have to take off a whole day of work to get a mammogram, people are going to miss them. The loss of rural hospitals is a huge stressor on larger hospitals, and I think anybody who has been to the ER in the last few years could attest to that. We lost our hospital in Mexico, they lost their hospital in Fulton, and now we've all been driving up here. And we can see that when we come to the emergency room now. When my husband had his heart attack just a couple years back, we waited for hours upon hours upon hours, despite urgent care calling ahead to tell them he was having a heart attack and that we were on our way. The second heart attack, urgent care sent us by ambulance, only for us to sit in the waiting room for nearly 12 hours again. I went in just a few months later after 30 hours of nonstop vomiting and faced the same sort of wait before having an emergency appendectomy. Those wait times are increasing for everyone, rural and urban alike, as we can see continued concentration of care. As wait times increase, bad outcomes increase. A lot of you in this audience already worked really hard to protect access to health care in rural Missouri. You fought hard, you got signatures, you knocked doors, and you voted for Medicaid expansion, which was a really important step in stopping the bleeding. Medicaid makes up almost 20% of rural hospital revenues, and when combined with Medicare, that jumps up to 72%. Now, with the attacks on Medicare through the One Big Beautiful Bill at the federal level and HJR 154 at the state level, work reporting requirements are about to tear off that bandage. More than 18% of rural residents rely on Medicaid to access health care. This means that Medicaid dollars are helping to keep our rural hospitals open. Rural populations tend to be older and sicker, and there are less available jobs. For many towns, ironically, the hospital that they used to have was the biggest employer. The proposed changes to our state constitution in HJR 154 would have staggering impacts on Missouri, and we fear our rural communities would feel these impacts the most. Federal work reporting requirements mandating 2 reporting periods per year are slated to begin in January of 2027 and are already anticipated to cost the state more than $215 million annually. HJR 154 would increase those reporting periods to every single month. Those potential additional costs to the state would come at a time when we are already facing a $2 billion shortfall. And we know that 90% of recipients are working or exempt. They're already working or already exempt. Yet 170,000 Missourians stand to lose coverage if this bill is made law. The possibility for administrative error, whether processing reported work or reported exemptions, gets higher the more times we add a checkpoint. If an exemption isn't processed, if something isn't entered correctly, that deserving person would lose access to the care that they need to live. And the time to get these errors corrected could cause deadly delays in care. There are also no hardship exemptions included in HJR 154. You will still have to meet these reporting requirements and get them processed on time if your town is wiped off the map by a flood or tornado, or you get unexpectedly sick or hospitalized. When will these politicians finally learn that our fates are intertwined? Politicians will seek to divide us, but in reality, we're all in the same emergency room, we're all in the same boat. In situations where minutes matter, what happens when patients are faced with hours of drive and wait times? We know that preventable deaths will happen. We saw it before we expanded Medicaid, and it will happen again. Our rural families, communities, patients, and healthcare providers deserve better, not the threat of additional cuts. Luckily, the people in this room can help once again. This Wednesday, the Missouri Senate Families, Health, and Seniors Committee will be holding a public hearing at 8 a.m. on HJR 154, and I urge all of you to come and testify that these reporting requirements will be death by paper cut and bad for Missouri. Talking points and information about how to reach out to MRCC to get involved with our healthcare work, I can pass that around to you as soon as I get finished speaking here. Thank you so much for listening to my voice tonight, and thank you in advance for raising yours in support of patients throughout our state.
Thank you. Okay, for this topic, we've got 2 speakers. The first one is Jeanette Cass.
Hi, my name's Jeanette Cass. I'm running for Congress against Mark Alford. I'm so glad you're here today, Mark. Thank you. I'm gonna have to get a picture with him before we leave. But I only get 1 to 2 minutes to speak. Alice said, pick one thing, and then I couldn't pick one thing. She said, just pick several. But I'm gonna talk about rural health care because I live in a rural area, and it just affects everybody. I had an accident, I had an argument with one of my cows, and she decided to break my ankle out in the middle of the hayfield. And so by the time I crawled myself back to the barn, I had to call somebody to come and get me, and it took them 20 minutes to get me. It took me an hour and a half to get to the hospital from there. Had it been something even worse, gosh dang, who knows what would have happened. We have a serious problem with our health care in the United States of America, and we need people to go to Congress who are willing to fight to fix this problem. As somebody said earlier, it's time that we should all get health care. We're spending something like $91 billion to foreign countries every year. Guess what they get? Health care, free health care. And a college education free too, but we won't go there. So if we're sending all of this money to help these foreign countries, then why the hell can't we have it here? It's time for us to start taking care of Americans. And then we have the president, or was it JD? No, I think it was the president that came out and he said, listen, this war's going to cost us so much more money. We're going to have to cut some costs. And he said, we're going to send things like Medicaid, Medicare back to the states. You're giving me 30 seconds. Back to the states to get it ratified at the state level, because all he wants to do is spend our tax money on our military. And gosh dang, guys, we're the United States of America. And she's going to get on to me. We are the United States of America. It's time to start acting like the United States of America and start taking care of all of the people in our country. So, thank you very much.
Thank you so much. All right, Peggy Neal Lewis. You can stand right here if that makes you comfortable.
Okay.
1 to 2 minutes, please.
Yeah, my name is Peggy Neal Lewis, and I'm a registered nurse. I've been practicing for over 50 years. I grew up in mid-Missouri. I'm a rural person, and I am now, I continue to be a partner in my family farm. And I am increasingly concerned about the ability of my family, which most of them are still in the rural area, their ability to get to health care. Just for one example, a couple of weeks ago, I got up, drove to Mexico, picked up my brother, drove him to Jefferson City because that's where his specialist was, then drove him back to Mexico and drove him, and I got home around 5 o'clock, okay, or 6, I don't remember what it was. But this is not my story only. There are so many of these stories. He delayed getting his tumors removed from his bladder because he didn't want to bother us. He didn't want to, and this is a characteristic of my group, my age group. You know, we want to take care of ourselves. And so this is an issue for rural Missouri. There's no question. And also the bottom is falling out of health care. Everybody's saying, oh, we have accessibility, we have this, we have that. But we have the bottom falling out of health care here in the United States. We are buying drones, we are buying jet airplanes, we are sending our people over to fight a war that we haven't even authorized, and we can't even get health care. And so we have got to get our issues realigned so that they meet the needs of people here. I'd like everybody to stand up who lives within 20 miles of a hospital. I'm going to tell you, I have 200 people in my family. And if I had done that with them all sitting in here, there might have been 15 people who stood up. So I am grateful that I am retired and I'm a nurse, because they call me all the time. Thank you.
Thank you, Peggy. Thank you, Peggy. Thank you. And thank you for being a nurse. You know, there's a group here that needs to be listening, and they're not. And I want to share with you just briefly a story that happened last session. The most rural Republican stood up, and we were talking about something. He has 800 miles of dirt road in his district, and he was talking about the same sort of issues that we're talking about here tonight, the exact same issues. And his own party stood up and told him to sit down with a PQ. There's no shortage of opportunities for improvement in our state. So Anyway, just to let you know, there's some folks out there that are experiencing the same sort of thing, but there's a whole heck of a lot of them that are just making sure that we don't have a voice. So thank you for coming out tonight and using your voice. I appreciate that. Next up, we have talking about veterans and their health care issues. We have Reverend James Patterson.
Thank you. I am so proud to be a veteran, you wouldn't know. One of the things that I wanted to share, and I'm going to keep real close to watching my watching at time, but the one thing that you need to know is that I come from a family of veterans. My brother, who was in the Navy, was on the USS Hornet, who picked up the astronauts who came from the moon. Isn't that kind of a coincidental? And if our voice sounds a little shaky, it's only because he and I talked for 2 hours before I got here about veterans affairs. See, the thing is, we all have had to go through something. I just recently had eye surgery, cataracts and glaucoma, so you see these shades and stuff. I'm light sensitive, so I wear my shades pretty much all day long. But the thing is, I'm so grateful and so thankful for what I have. But I wear a black jacket, and on the back it says, I had a DNA test. God is my father, and veterans are my brothers. And so what I'm saying to you is that I support those who I have served with, who I've grown to love, who I've worked with, and who I know even now. See, the thing is, there are a lot of things that are offered, but there's a lot of things that have been taken away from us. And we have to fight for the things that got taken away. See, Angus King, a senator from Maine, in front of the committee said, there are 585 contracts that have been canceled. 585. And you know what the question he was asking? Where's the list? Why are you hiding something? If I want to keep a secret, I don't go tell anybody. I keep it to myself. Yes, contracts with the VA. Thank you. See, I'm getting some help. Yeah, contracts with the VA. And so consequently, everything has a consequence. And I'm one to know that talks about the laws of unintended consequences, also talk about connecting the dots. You wonder why I'm connecting these dots, because I'm a vet, yeah, but I'm a human being who has frailties and who gets sick and all of these other things. And so I fight for the causes that I'm passionate about. And I'm passionate about veterans. One of the things that I wanted to share with you is, and I turn back here right quick. Okay, one of the things I wanted to share with you is like veterans have an issue with housing now. They've taken away houses, so if you lose 10,000 houses, what does it do to your psyche? What does it do to your mind? What does it do to you physically? What hurts you mentally can have an effect on you physically, so we want to look at that. Those foreclosures, 10,000, can you imagine? Other impacts include staffing shortages, forcing clinics to cancel appointments. Can you imagine those who are in rural places who have to come here to the VA in Columbia, Missouri, and you get there and they tell you, we don't have time for you? Can you imagine? That's one of the issues that I have. Now, the key program cancellations and disruptions, VA home loan program ended in 2026, remaining critical foreclosure protection programs for the veterans in financial distress are no more. Clinic appointments and staffing, due to the massive loss of VA employees, over 40,000 in 2025. Now imagine that. This stuff I'm getting from the United States Senate Committee for Veterans Affairs, so you can check my work. And the thing is it has such an important impact on me because I know veterans. I know people that serve. And so can you imagine clinic appointments and having cancellations? Estimated 1.2 million veterans losing their provider. 1.2 million. Here in America? Come on now. transition assistance programs suspended during government shutdowns, leaving service members without required transition briefings. Regional offices and services, benefits regional offices closed to the public during shutdown scenarios, stopping personal services. What about this? The hotlines and the counseling, the GI Bill hotlines and veterans readiness and employment counseling services have faced closures and suspensions. And this got me. And then I'll sit down, I think. Cemetery operations. Those who have served, who have given their lives, who've dedicated everything that they had. They had the audacity. This is me, because I can get, y'all know me, the ones who know me know I get fired. Routine ground maintenance and the installation of headstones were halted during the shutdown. Did y'all hear me? Okay, that's just me. But what I'm saying is our reverence for the servicemen. It's good to say thank you for your service, but it's a lot better if you do something about that. See, I'm the one that will do something about that. I'm one that if you find me being passionate about something, you will see me somewhere. I wouldn't be surprised if you haven't seen me somewhere already, because I'm so passionate about things. But when we talk about veterans, all my brothers, with the exception of one, because he was smart, were veterans.
How many veterans are here right now?
How many veterans are here right now? All right, amen. Well, we keep on fighting the good fight. See, the thing that I came to talk about, yeah, I can tell you about all the statistics, and I gave you my reference for my information. I gave you my sources, so check it for yourself. But what you will find, it is a hard read for people who are passionate about their fellow service members. And I've been told to stop. Thank you very much.
All right, we've got one audience member, Verity.
Okay, so I served as a combat engineer, 12 Bravo, in the United States military. I went overseas to Iraq in 2005. I served for 1 full year. I didn't like the war then. I don't like the current war now. I think both of them are completely irrelevant to America's current needs. I feel like we could be taking all of that money, we could be redistributing it anywhere and do infinitely more good than what we're doing with it right now. I want to talk to you for just a second about trans healthcare and vet care. When I finally got the courage to go to the VA, I served during Don't Ask, Don't Tell, I was completely scared when I walked in the door. I thought that the fact that I was panned was going to be a big deal, and it was for a little bit. I got lots of testing done because they were pretty sure that I had some kind of venereal disease or something. I don't. I've been checked completely thoroughly. I can assure you of that. But one of the main things that did cause a hang up for me, I thought since Biden was president during the time, and since Biden had done a lot with the VA to kind of lift this stigma behind trans people coming in and getting care, I thought that the day that I showed up to the VA, I would be able to show up, give them all of my information and be like, look, I know that I look this way, but give me about a year on estrogen, please. I'll look the complete other way that I should have looked. And that was a hard conversation. It was a hard conversation because it stopped. The second that I walked up to the VA and I gave them my identification and I asked for them to print off for me an ID, the woman looked at the paperwork, saw that I had marked down female, and said, wait a second, we need to change something. She took the paperwork away, saw her in about 10 more minutes. Oh, we've got everything set up for you, Mr. Tatum. Don't worry, everything's been attended to. So then I looked down at the paperwork and I was like, okay, this says something completely different than what I marked on the paper before. Why is that? You can take that up with your doctor. Okay, cool. So show up, start talking to the doctor. Hey, I'm trans, by the way. And I know that we have started to move things towards a more informed consent model. So I should be able to go ahead and get access to care, right? You're gonna have to talk to someone else. So then I jumped through every single hoop. By the time that I did, I moved. Don't ever do that if you're in the VA system. Don't ever do that. No, because I moved to Virginia. They forgot I was a non-entity. I had to fill out every single piece of paperwork again. That is what it's like being trans and trying to get health care and also being a veteran. There are 165,000 of us by estimate. And it's incredibly hard for any of us to hold on and try to ask for health care in those environments, which is why I haven't. At long last, I was like, I can't keep up with this. What I need to do is I just need to go out and I need to get my own private health insurance. Let's do telehealth instead. In 15 minutes on telehealth, I had access to the health care that I needed. I should have been able to do the same thing the day of at the VA. Anyways, that's kind of what it's like. It sucks. It sucks for veterans that are not trans too. It sucks for everybody in between. And I wish I had more time to talk to you about the types of things that you would have to go in through with therapy for don't ask, don't tell, and all those things, but I just don't have time. You're all wonderful people. Somebody get me off of the stage now.
Thank you so much, Jordan. Thank you, Verity. Thank you so much. From your mouth to God's and these people's ears, if you please. Yes. Our very last person, and this is something that's already kind of been mentioned here a little bit tonight, but I am going to let him do kind of the bulk of this. I'm really excited to hear about this. This is Dr. Jeff Belden, going to be talking about removing the middleman from Medicaid. I'm so excited. Thank you for being here, Dr. Belden.
Thanks for inviting me. Now, when I was practicing, I was using both hands to do this, so I'm not sure about the microphone. I'll do my best. Let me know if you can't hear me. So I'm a happily retired family physician and also a member of the Physicians for a National Health Plan who've been working on things for a while, and we see an opportunity. So 1 in 5 Missourians uses Medicaid each year. Right now, we pay insurance middlemen to stand between the people and their doctors. And Medicaid isn't some niche program. It's the backbone of healthcare for children and for rural Missouri. It keeps small town hospitals open, rural clinics open, and to make sure that kids can see a doctor before small problems become big ones. So when we decide how to run Medicaid, we're deciding whether rural hospitals survive and whether Missouri children can actually get the care that they need and not just a plastic insurance card. Or paper insurance card, that's the kind I get now. So today, much of Missouri's Medicaid program is run through private insurance companies that the state pays to manage Medicaid. These are the middlemen, and I keep mispronouncing it metalmen, but it works either way, middlemen or metalmen. They sit between the public dollars and patient care, collecting administrative overhead and deciding which doctors are in-network, which medications are going to be covered, and how much hassle it takes to get something approved. We know already that Medicare can run complex care without handing control to insurance companies. The most medically complex Missourians are those on Medicaid, the aged, the blind, and the disabled. They're already served by the state without insurance company middlemen. So here's why this matters for the budget. When Missouri is run by private insurance middlemen, the administrative overhead runs around 13%. When the state runs it directly, it's closer to 3%. So that 10% gap is not going to patients, it's going to bureaucracy and profits for the insurance companies. For Missouri, that difference adds up to about $250 million per year. $250 million per year. That could instead be stabilizing rural hospitals and improving kids' access to care and paying for mental health and women's health services that my fellow panelists have talked about tonight. We also note this isn't just theory. Another state, it turns out it was Connecticut, the U.S. insurance capital of the nation. Connecticut removed these middlemen. They saw more doctors taking Medicaid, and they saw better early cancer detection and cancer survival. So when more dollars go to instead to insurance, let me try this again. When more of each dollar goes to Medicare instead of insurance companies, access improves. So what do we do now? What do we do with this? First, we should say clearly that health care for citizens through a public program like Medicaid should be run in the public interest, not by insurance middlemen. That's something Democrats and Republicans should both be able to agree on. So if Congress cuts Medicaid in the years ahead, like the BB bill has intended, the appropriate response is to cut insurance company overhead, not cut children, not rural hospitals, and not people with disabilities. You remove the middlemen. That's how you protect people while being careful with public dollars. Second, Missouri should plan on bringing Medicaid back under direct state administration instead of renewing another round of long contracts that go on for several years to pay the insurance middlemen, to ration care. If we absolutely must compromise, we can use administrative service organizations, ASOs. That's my only acronym for the night. I've protected you from a lot more. Those ASOs just handle the paperwork without getting their mitts on the profits. But the goal should be to stop paying insurance middlemen to ration care. And timing matters because with the next round of Medicaid contracts approaching, the question must be answered right now, not someday. So here's the question to carry out of this room with you. Are we willing to stop wasting public money on insurance middlemen? Ask every candidate you meet, local, state, and federal, whether they're willing to stop paying corporate middlemen to ration care in Missouri Medicaid's program. Because if we get the middlemen out of the way, then the dollars we're already spending can do what they were intended to do. Keep Missouri hospitals open and get real care to Missouri's children and families. And I'm done a minute early. That's a good meeting.
All right, we have two audience members who would like to speak on Medicaid issues. Sekou?
I was going to start with me, but trans people are people. You don't have to, Cliff. Women are people. Let's treat people like human beings. It's 2026. That's it. I tried to get up from being killed and get my life together, and the head injury got me the help that I desperately needed, but I'd rather be whole. It's always a struggle. You need help, but you're forced to wait on the government to decide your fate. The government, plainly put, has collected our money, and now some plan on not paying us back when we need it. In the end, people are dying. That's all I care about. That's why I'm here. That's why I'm speaking up for all of us. A healthier society, a happier society, a helpful society costs less for everyone. It has been proven in Norway and other countries that see taking care of each other as a public service, not a grim duty to be avoided whenever possible, as if it's portrayed so often here. Numbers are great. They're great. But I feel we should do the right thing by people because it is right and just. Let's treat people like people. It's 2026 and we deserve better from and for ourselves. That's why I'm working with the health ministry at my local church, as we can both eat good and eat well to healthier outcomes. In my opinion, preventative care makes for a happier, healthier, wealthier society.
Deb Finley?
You know, I worked for years in the welfare system. 4 years about doing Medicaid eligibility. So that was a long time ago, but I know the process you go through. Oh my God. When we put my mother-in-law in a nursing home, trying to get a hold of the state to get that application in was horrendous. My husband, I didn't do any of it. I was trying to let him do it. He's a pipe fitter. And I didn't want to act like a know-it-all. But he would be on the phone waiting forever to try to talk to somebody about eligibility. Oh my God, that was one, he had to do it every year for the whole time Gloria was in the nursing home. When I heard that they were getting ready to start work requirements, that meant you had to do your eligibility every 6 months. Holy moly. That is ridiculous. And I mean, we are not stupid people. In fact, I should have been able to help him with the application, but I just decided not to. I had other fish to fry. But it's not fair that people are treated in that manner. It was just really horrible. And, you know, we have contributed to society our entire lives. His mother had as well. And yet they were going to put us through that every year. And now it would be every 6 months. It's horrible. So I did want to bring that up. But I do want to kind of drift back to the veterans. My veterans are a special place for me. My dad was a disabled veteran from World War II, a paratrooper. He worked at the VA hospital, and I was a librarian there in high school. You were talking about the mortgage, what was it? The mortgage relief program or something? It's coming home here. My son's next door neighbor got evicted March 15th. We looked it up on the county clerk's site. You know who owns his house now? Veterans Affairs. His mortgage was slipped out and away from him, and now he's probably homeless and has lost his home. It's happening here. All the things that we are talking about, all the things that were talked about in 2025 are happening to your neighbors here. So that's all I have.
As moderator, I just want to thank everybody for their stories. These have been very powerful, and I'm going to introduce the very last speaker, who's going to talk a little bit about mental health care. My co-moderator, Representative Greg Bush.
Thank you, Paul. Thank you for sharing these really personal stories and for speaking up. Again, we just need more ears up here. There is no irony that I'm going to be talking about mental health, to be clear. But let's talk about a couple numbers. In the last 20 years, under single-party rule in this state, we have lost half of our psychiatric hospital beds. We had more than 4,000 psychiatric hospital beds in 2005. We have less than 1,900 today. We've lost a third of our hospitals. We've lost 20% of our med-surg beds. That's my tradition. The kind of nursing that I did was medical surgical nursing. And let me tell you how that is going to impact just mental health, generally speaking. If you are in a mental health crisis, you may be brought to the emergency room by a family member, by law enforcement, and you are given a medical screening at that time, and you are medically cleared before you go to an inpatient psychiatric bed. If you have COPD, or if you are having pneumonia, or if you have some other kind of medical issue, you came to my floor, where we treated you for your medical issues and put your psychiatric issues on pause to go to inpatient psychiatric stay. When we lose med-surg beds, we lose the ability to care for people before they can actually work on their psychiatric illness. When we lose psychiatric beds, we lose the capacity to care for people who are in psychiatric distress. That is what's happening in this state. And there's been a lot of bad news here tonight. I want to share with you a little bit of good news, because when you're down in Jeff City in this super minority party, you got to hang on to every little bit of good news. We heard a bill in committee for a court-ordered outpatient therapy. This is for people who have a psychiatric diagnosis, may have some kind of interaction with the judicial system, but they don't get to be incarcerated. They instead get court-mandated therapy with wraparound services that includes case management. That's a win. It hasn't been signed by the governor yet, but we had a Democrat and a Republican sitting up there and saying, this is something that we need. The current mental health care system works, we'll put that in quotes, works for about 80% of people. That other 20% maybe just need a little bit of extra help. So that's something that we heard and was very well received. Something else that we heard that was very well received is something that's with managed Medicaid, state managed Medicaid, of something that we're calling gold carding, where if you are a physician and 90% of your interventions are going to be approved by your insurance company, you don't need to go for pre-authorization anymore. It's going to let doctors be doctors and not be somebody waiting on the phone with that whole music asking, Mother, may I, from somebody in Colorado who's never even laid eyes on a patient, please can I treat the patient that's in my room? That's something that we heard that has actually gotten off the floor and has moved on to the Senate. So that is, yes, that is some good news. That is some good news. There's a handful of other things that are good news in terms of health care. But the reality is this coming out right now, and maybe seeing people that you don't necessarily know, all sharing that experience together, listening to other people's experiences. These are the webs of community that were severed, particularly during COVID. And this here of coming out and bearing witness is a part of mental health care, community health care, and that you are doing this and that you are craving this and being here with each other. Thank you for doing that. I'm going to ask each and every one of you to take, not just be a human jukebox and repeat stories later on, but really sit with some of these human beings that were courageous enough to share of the things that they're going through. And go and talk to somebody that maybe you don't know. And don't let people get away with, oh, it's just both sides. Because one side is here tonight and one side is absent.
And we do have one community member here for this one. I would just like to thank both Devin McTighe and Jen Harper. They helped organize this. And I will let Devin round up as the final audience member, and I'll even give you the last word.
Thank you. Hi, everybody. Thank you for being here this evening. I really appreciate it. Healthcare is something that I'm very passionate about because I am a disabled Black woman. And I stand here as someone who deals with the mental health care system, someone who deals with the Medicaid system, and someone who has dealt with the healthcare system in Missouri for over 20 plus years as someone who is disabled. The Medicare system and the Medicaid system in Missouri definitely need repair and fix and care. People who could have better outcomes are lacking those better outcomes because our system is broken. I can tell you from personal experience, I struggle with getting some of the care that I need because I do not have the access available to me because of how Medicaid is run. I am not able to get some of the mental health care that I need because of how Medicaid is run. I don't know if you all know this, but they were trying to cut Medicaid services to a lot of providers here in Columbia that keep us from being able to access that care that is needed. The kind of care that I need, I cannot get because I don't even have a specialist that does that kind of care here in Columbia. They don't have those specialists here. You'd have to go out of town to St. Louis or Kansas City in order to get that specialist. I've tried to do other types of therapy to kind of help bolster it, but it's not the exact therapy that I need. And so I wanted to remind you all that know that your neighbors may be struggling getting health care and that to reach out to your neighbors, don't be afraid to talk to people and find out what's going on with your neighbors so that you're able to help care for each other and actually make a difference in what's going on with our healthcare system, because each one reach one, you know? Especially those with mental health care issues. I stand up here as someone who has agoraphobia. I stand up here with other mental health issues. But I'm doing this because I know that people need to know that these things exist and that we actually need to do something about them. And I want to say that thank you all for being here this evening. Thank you for sharing your stories, for being brave enough to stand up here and talk about what's going on, because that's how we make change. So thank you all for being here this evening.